Hi, I'm Dr. Jerry Hesch from the Hesch Institute in Aurora, Colorado. I'm a physical therapist. And this client has hypermobility syndrome, in which her joints are more lax than the average person. And so here's an example of that. I can hyperextend her knee. Sorry, can you lend me an elbow? And you can see that she has what's called a gunstock deformity in her elbow, and hyperextension in the, well, you know, not so much.
Mm-hmm.
So she has a degree of hypermobility, but it doesn't affect her distal joints as much as more proximal joints. So we would call that a mixed hypermobility. But she suffered a fall onto her sacrum and fractured the sacrum, and that was quite some time ago. And you've developed kind of almost a whole body pattern. And you've seen how many practitioners since then?
Probably at least 20.
Okay, about 20. And when was the fall?
2011.
Yeah. So you've really been struggling to get this under control. Mm-hmm. And in spite of that, you still have a very high pain level of 5 to 8 out of 10.
Yes.
So it really does impact your tolerance of sitting at work. And it certainly impacts your sleep. So I'll show you the pain drawing if you can come close to that. And she is aware of having a restriction in a rib. And of course, a lot of pain in the pelvic region and lower quadrant. So let's have you lie on your back. I did screen each region of her body and screen the hips and the foot and ankle, and quick screen on the knee. On the pelvis, she presents asymmetrically. So this pelvis is lower on the right. This part of the pelvis is lower on the right compared to the left. And so the question is her pelvis, does this asymmetry alter movement, or was she developed this way? And so I'm doing a passive, what I call a spring recoil test, and I'm trying to take up the slack, and there's no movement. And this is a fixed amount of force that I've been trained to apply to pelvises. And we do it on this side, and you can see there's movement. And the movement stops, and then I can bounce it. And I can thrust it forward, and it recoils backwards. So based on this restriction, we call this a right anterior ilium, but in truth, it's not necessarily the ilium rotated on the sacrum, as is a very popular explanation, but it's more a twist throughout the whole pelvic structure. And the pelvis moves on the hips, on the femoral heads, and it moves in relationship to the trunk and the lumbar spine and such. All right, so let's have you lie on your stomach down. And congruent with this pattern, her ilium is higher on the right side, and I can create movement in rotation. And coming over onto the left, I can create movement in rotation, and I can create inferior glide. You can see the heel bouncing up and down, so the force translates through the SI joint, through the hip, on down to the lower extremity. But on this side, it doesn't move. And that's just because the pelvis is twisted in such a manner that it acts as though this ilium is rotated forward. It reduces movement in that direction. However, there's movement here. She can actually move up into that pattern. She can go further into that pattern. In sitting, the sacrum takes on a twist in which movement becomes blocked in the left lower quadrant. And I'll demonstrate that in a short while. But in prone, I can get movement on that left lower part of the sacrum. And the only other significant finding I have in terms of mobility, as she mentioned, she feels like a rib is stuck. And there is good mobility when I spring laterally on this group of ribs, but when I come and try and spring that rib in towards the spine, we have one that is distinctly not moving. So I don't like terminology like her rib is out. The terminology I like is the rib has moved through its normal range of motion but became stuck. So I treat mobility dysfunction. I don't talk about things being out of place. That's crazy talk. So this rib I can't spring. I'm putting a generous amount of force. It does not spring. And I come to the one above it, and I'm medial to the scapula, and I can get mobility. Again, this one is stuck. I come here, and the one below it springs. So we will certainly treat this rib to restore medial mobility. Can you sit up and face the bookcase? Now, when the spine is flexed, if someone has what we call a sacral torsion, that will accentuate. And I have my thumbs on our PSISs, so upper sacrum is right here, and I can push through that sacrum, induce movement through her body, and I can do it on the left side. And then I come down to the lower sacrum, and I notice that this thumb projects out towards me. And I spring the sacrum on the right, and it moves. And then I spring it on the left, and it doesn't move. Now, I wrote a book chapter, 43 pages, 147 references on sacral torsion. But to this date, no one has done the research using the best testing available, which is called stereophotogrammetry, to look and see if sacral torsion really happens inside the SI joint. And so I'm a little conservative in saying that the sacrum is really twisted. It could be a muscle phenomenon making it appear such. But again, I treat movement, and this is blocked movement, and therefore I want to restore that so that next time in sitting, I can induce movement through this bony structure on the left, which I cannot do right now. So this is a summary of the quick and easy findings on the first assessment of her body, and we certainly will treat these things that we pointed out, and we will continue to do whole body screening with her, but this is the primary, very obvious restrictions that I found. And I hope this is an informative video. Thank you.